So welcome to this webinar on lab research for WM. I look very sweaty. It's because I've just moved into my new address and the guys are still bringing stuff in now, as you can see behind me. Today's webinar is, we're very pleased to welcome Professor Dr. Roger Owen from Leeds. Some of you know him. He's from Leeds, way up north. He's very keen and into the research that goes on in relation to WM. He's also a trustee of WM UK, very valuable member of our trustees group, and he's a big supporter of WM UK, and I thank him for that. And he's going to be talking to us today, as I say, on lab research. It's going to be a PowerPoint presentation to start off with, and then I'm going to ask him some questions. But because I've just moved in, I still haven't unloaded my book with the questions in. I can remember some of them, but what I'll do, if we've got time at the end, I will then open up to you to ask some questions of Roger, and we'll see how far we go with that. So, Roger, over to you.
Okay, thanks, and good evening, everybody. I'm very grateful to Bob for the invitation. I can see that he's put together a great program for you all. With all these webinars, I think it's a very good way for everybody to be keeping in touch. And I'll see if I can share my screen now. You can. So. Okay, so as I say, thanks to Bob for the invitation. And essentially, I wasn't entirely sure what was wanted of me in terms of what we wanted me to speak about, and we had a briefing session towards the end of last week, which was very useful. And he basically gave me two principles to follow, and that was keep it simple and send us home optimistic. So I will try and do both of those. So actually, when I was putting some slides together yesterday, I was kind of wondering what I might include in this talk, and then actually when it came down to it, I actually had quite a lot of slides I could have used. Hopefully I've not made this too long, and there is a sort of phrase that people have used: if I'd had more time, I'd have made it shorter. And I'm kind of interested in that phrase. And actually, apparently, this has been first attributed to Blaise Pascal in the 1600s, and but it's been attributed to a whole bunch of other people like Benjamin Franklin and Mark Twain and others since then. But I say, hopefully, this will be relatively short and will allow us a bit more time for discussion, which I think will be more meaningful and a more didactic presentation. So, and just thought I'd sort of talk you through the principles of research and how it's done, and what sorts of research there is, and some things you might think maybe doesn't count as research, but is very much important. So I think what many of you think is research is basic hypothesis-driven laboratory work, where you generate a hypothesis and you test it in the lab and you come up with an answer. And that's a very important component of what's done in all medical research, and Waldenstrom's is no different in that respect. And this is the sort of research that tells us how the WM cells behave in the bone marrow, what their requirements are, what their susceptibilities are, what are potential new therapeutic targets. And they can be tested in the laboratory as well, using both what we call WM cell lines. So these are immortalized cell lines, or indeed primary tissue samples. There's what we call so-called translational research, and that's more or less what I do really. And that is to try and join the laboratory and the clinical together. So are there things that we can detect, measure, evaluate in the laboratory that will allow us to provide better clinical care? Can we monitor response better? Can we predict outcomes better? Can we choose better treatments? That's the sort of thing. There's obviously clinical trials, and thankfully there are more and more clinical trials now, and there are obviously several of you on the line today who've participated in a clinical trial, and you know the benefits that potentially can bring. And the translational elements and the clinical trials often go together, so that we would be looking at biological parameters, laboratory parameters, bone marrow-based parameters, and look at the outcome of that according to the therapies that patients have received. So I think it's important that there is a laboratory component as well as a clinical component to all clinical trials. And one thing that we shouldn't underestimate, and that's the value of sort of real-world data. And I think the regulators and NICE and bodies like this are coming to realise the value of real-world data, and are using it more and more in terms of their assessments of treatments and their evaluations. And I think this is important. It's particularly important in a rare disease where there may well be a paucity of such data, and obviously the support of the Rory Morrison registry is very important in this regard. And I've just put up the 3 principles of serendip there, because I think sometimes things just come by chance. So, we shouldn't undervalue the potential role of serendipity in any discovery. So let's just see where we currently are and what has been achieved. So obviously the disease is relatively young in its description, originally described in 1944. And again, this was through observation and some laboratory work on the part of Jan Waldenstrom. And effectively there was a lot of debate for many decades as to whether it represented a real disease or not. I think that has been finally put to bed now, with particularly now that we have a disease-defining genetic abnormality, the mid-88 L265P mutation. So if we think about what has happened from the original discovery of and description of the mutation in 2012 to where we are now, there has been a huge amount of progress, and that's, so I think there's a direct link there between laboratory work, target discovery, drug testing, and formal approval of drugs by regulatory agencies both in the US and Europe. So, so I think there's, in that story, there's very much a clear link between scientific laboratory-based work and treatments and real benefits of patients. So if we're thinking about research and thinking about questions to ask in WM, I think it's useful to just remember what WM is. And this is a very simple model. I include this in pretty much all the talks I give, and this just shows you that WM is a unique lymphoma in that the cells are not halted at a specific stage of their development. For most other lymphomas, the cells are frozen at a particular time point. In Waldenstrom's, you have what's called differentiation, and this mimics what happens to normal B cells actually, and that is the B cells turn into or develop into plasma cells, and we call that differentiation. And these two cellular components are part of the disease, but they're responsible for different components. And the reason for this is that the B cells are probably, for most patients, they will be the predominant cell type. These will be the cells that are generally responsible for what we'd call the bulk symptoms. They'll be the ones that will be infiltrating the marrow to a great degree, causing anemia, maybe causing lymph glands, spleens, and that kind of thing. Whereas the plasma cells are likely incapable of cell division. So they're the end product of that differentiation process. but they're the immunoglobulin IgM factory. So they're the cells that pump out the IgM. So they will obviously have a direct relationship to the clinical properties that we might want to attribute to the IgM. And that could be hyperviscosity because there's loads and loads of paraprotein, or this could be some of the IgM related syndromes. So these are things that specific clinical features that we would attribute to either the physical, chemical, or immunological properties of the IgM. And there are things like peripheral neuropathy, the MAG neuropathy, cold agglutinin disease, cryoglobulinemia, amyloid, and a whole variety of things. So we should maybe think about patients and the clinical features, and then sort of frame that back to that simple cellular model. So just returning to the sort of underlying genetics, and obviously the MYD88 mutation was described in 2012. It's present in the majority of patients, at least 90% of patients will have it. It's what we call a point mutation, so it's a single change in your genetic code. And this is acquired, so this is only present in your lymphoma cells. This is not an abnormality you've inherited from your parents. It's acquired during your lifetime. It will likely have been acquired many years prior to your formal diagnosis. And there are a whole bunch of other mutations, and the second commonest being CXCR4. It's probably, the incidence is probably a little bit higher now that we can test for it a bit better, but somewhere in the region of about 30 to 40% of patients will have the CXCR4 mutation. And again, this is acquired and not inherited. And then there are a range of other more rarer mutations that we don't really know the significance of them because they're present in a small minority of patients, and they're not really viable therapeutic targets if they're only affecting 3% of patients. So this, Bob said keep it simple, and I've failed already. So if you look at the left hand, image, you can see we know quite a lot about MYD88 and how it's involved in the kind of signaling process within the B cell. And there's a very complex cascade of events that results in the activation of the cell. And just the simple thing to see here is that MYD88 forms a complex with a range of other molecules, including BTK. And you can see, therefore, that there's a very close relationship between MYD88 and BTK, which is the ibrutinib or acalabrutinib zanubrutinib target. And we can see that this mutation is important to WM cells. And if you look at the top graph, you can see that there are red lines, blue, purple, and green lines. The two red lines are the two WM cell lines. So these are immortalized cell lines derived ultimately from patients that we use in the laboratory to test stuff. And in this situation, you can do what's called MYD88 knockdown. So if you inhibit MYD88, you kill the cells. So what that's telling us is that MYD88 is essential for the growth of WMB cells. Cells who lack the mutation don't respond to that treatment, which is the green, purple, and blue lines. And if we then replicate that experiment, but we include ibrutinib rather than the MYD88 knockdown process, you can see that the cell lines that have the WM cell lines, which is the BCWM1 and the MWCLL1, you can see that there is a dose response effect with the ibrutinib. So WM cells in the laboratory are killed by affecting MYD88 either directly or through BTK inhibition with ibrutinib in this instance. So just to say, we do have a basic research group here in Leeds, and I've just put this up just in order to thank WMUK really. So this is some work that was funded by WMUK. Jenny Shrimpton was a PhD student who was funded by WMUK, and this is the work that she did, working with my colleagues Ruben and Gina, and again they're looking at the
Sherry Yonkers
joined the meeting,
where we're looking at how the B cells respond in a specific culture process. So we can add in compounds, take compounds out, and we can see what controls that process of differentiation. So this is a paper that she published from her PhD probably 6 or 12 months ago now. So again, there's no real learning from this, but just suffice it to say that the work was supported by WMUK, and there has been some proper academic output from it. So thank you for that. So what are the questions in WM? And when I was thinking about this yesterday, actually there are loads of them. So this is a personal view, and this isn't necessarily a comprehensive list, and we won't go through all of these, but just a sort of flavour of the things that we should be thinking about trying to deal with in the coming years. So I'm interested in diagnostics, so I spend a lot of time in the laboratory, and so we'll come on to that in a second. We also need to be thinking about models of outcome prediction. So can we inform patients better how they're going to do in the long run? And that's valid for both patients with asymptomatic disease as well as patients who are on treatment. Can we develop therapy that's tailored to individual patients rather than a one-size-fits-all approach that we currently take? Can we look at the Igm related disorders, the neuropathies, the cold agglutinin disease in a bit more detail? You know, do these patients have the characteristics of WM patients? Are treatment approaches in these patients the same? Should they follow the same principles? And in terms of the clinical trial setting, then obviously we still don't know what the best treatment for WM is. There's no real standard of care. Should all patients have a BTK inhibitor up front? That's a valid question, and there are parts of the world where that has become de facto the clinical practice. But if we are designing clinical trials in the UK, we need to be cognizant of the fact that we should be trying to develop healthcare combinations and treatments that is still deliverable in the context of a publicly funded health service. So there's no point in us evaluating something that will never ever get through the health economic evaluation at NICE. So one of the things that has cropped up now, certainly in the context of ibrutinib, is that once you're on a BTK inhibitor, you're on it for a long time. And that has some disadvantages for some people in terms of long-term chronic niggly side effects and those sort of things, as well as some more significant adverse effects, like hypertension and atrial fibrillation and those sort of cardiovascular risks that we do see. So there's work that's happened in CLL to see whether are there combinations that we can use that can be more effective, can deplete bone marrow disease quicker and more effectively, that might allow us ultimately to have a block of time-limited therapy such that there is a significant time off treatment period. And the other thing that we need to wonder about is, can we actually do trials quicker? Things are happening all the time. We need to
that was incredible. Obviously, whoever lost it.
Entirely sure. So
hold on, Roger, just a sec. There's somebody who's not on mute, and it sounds as though it's somebody in America. Can you make sure you're all on mute, please, except Roger? Thank you.
Yeah, and so I'll come back to performing clinical trials in a more meaningful time frame in subsequent slides. So just a quick word about diagnostic issues, and I think this is pretty relevant. We need to think about methodology. We need to think about the best ways to look for the various genomic abnormalities. We need to be sure that different laboratories are getting the same answers. We need to have tests that have got appropriate levels of sensitivity so we can pick them up when they're present at low levels in the marrow. For mid-88, that's not a big deal. It's a simple genomic abnormality, and there are simple tests that can pick that up, which are pretty sensitive. It's more complicated for CXCR4. And the reason for that is that unlike mid-88, which will be present in all your WM cells, CXCR4 is what we call subclonal. And that's because it's a secondary event. So it emerges in your WM cells typically after you've acquired the mid-88. So it's subclonal, so it's not present in all the cells. And there are a range of different ones. There are at least 30 or more CXCR4 mutations. And that provides quite a challenge for the laboratory in terms of detecting it. And I won't bore you with the sort of details of that, but that does that process where they're subclonal, so not present in all the cells, multiple mutations, difficult to detect. We should remember that when we are interpreting current clinical data and clinical implications of CXCR4 mutation status. So I think we need to be cautious about that. We need to look at what mid-88 wild type means. So wild type means you don't have the mutation. So there will be a minority of patients who have wild type disease. As I say, I mentioned about CXCR4 mutations. There are some patients who don't have WM by definition because they don't have an IgM paraprotein, but there are some patients who have a very similar disease, but they have different types of paraproteins. Now, we can't currently call those patients WM, and we can't access treatments that are highlighted for WM. So again, that's an unmet need, and if we can demonstrate that these patients have the characteristics of WM patients, then I think that will be a great benefit for that small group who are otherwise somewhat neglected. I've also put on here the potential for blood-based diagnosis rather than bone marrow. I guess that's something that many of you would prefer. I'm still a little cautious about this, but I think it might well be something that we can look at in the future. If you look at the bottom screen, you can see we've looked at blood involvement with WM patients, and the majority of patients, certainly those with active disease, have very low levels of cells in the blood, which we can detect. And this is the bottom plot here shows what we call flow cytometry, and the blue cells are normal and the red cells are the WM cells. And we can differentiate normal from WM cells based on basically on the expression of two things on the outside of the cell, and that's CD22 and CD25. So there is a potential for peripheral blood diagnosis ultimately. So just going back to the Igm related disorders, so these are patients who have a clinical feature that is attributed to pretty much solely to their paraprotein. And I guess the one we're most familiar with in that context is the MAG neuropathy, but there are a whole range of other things. There's acquired von Willebrand's disease, there's cryoglobulin, there's Schnitzler syndrome, and there's cold agglutinin disease. Now, what we haven't known up to now, at least, is whether, because these patients will typically have quite low levels of marrow disease, we don't know whether patients will have the same underlying biology that WM patients have. It looks like, and again, the data here is is not extensive and requires confirmation, I would say. But the data here would suggest that certainly the MAG neuropathy, the patients have features that would be typical, pathological, biological features that would be typical of WM, and maybe those patients, it's appropriate to treat those patients with a WM-like approach. But cold agglutinin disease is different. And cold agglutinin does appear to be distinct from WM in a range of ways. And maybe that's something that then will lead us on to be thinking about cold agglutinin disease in a different way and treating patients in a manner, in a different manner. So Bob wanted me to mention about watch and wait, and we need to get better at watch and wait. I think we basically tell patients with watch and wait that you've got a 50% chance of needing treatment in 5 years, and that's about it. So we have a very limited armory in terms of predicting and outcome for asymptomatic patients, but also in terms of managing them. We don't know the most appropriate interval. We don't know how to do it, how best to do it. Now there is a scoring system that was developed at the Dana-Farber in Boston, which uses these markers to stratify risk into 3 groups: low, medium, and high risk. Now, this isn't all that helpful, really. It doesn't help really predicting risk for individual patients. And it also means that patients definitely have to have a bone marrow to have that score done. So I think this is an area where we need to put some attention and see whether there's a way that we can predict outcome for asymptomatic patients better, but also work out the best way to monitor such patients, the intervals, etc. Similarly, when we're predicting outcome for patients who have symptomatic disease and require treatment, we use the IPSS. The IPSS has been around for 12 or more years, and that uses these simple indicators, age, hemoglobin, platelets, etc., to identify patients with good, intermediate, and relatively poor outcome. And again, this is good as it goes, and it's good for comparing clinical trials. So if we're seeing differences in clinical trials, we can compare the balance of IPSS, which might explain differences. But for predicting outcome for individual patients, it's next to useless, because there will be patients, we will always come across patients in whom we expect to do well, who do less well, and patients we expect to do poorly, who do very well. So we're still poor at predicting outcome. So just go on about clinical trials now. So this was the updated publication from the pivotal trial of ibrutinib from Steve Trion's group, published in the Journal of Clinical Oncology early part of the year. So this included 63 patients with relapsed and refractory Waldenstrom's, very high response rates, led to the licensing of the drug by the FDA and subsequently in Europe, and hundreds, if not thousands, of patients have subsequently received it. So the thing to note here is that curve is what we call a Kaplan-Meier curve, and that denotes the duration of the remission, something we call progression-free survival. So if you can, clinical trials, certainly in this setting, would typically be, we would compare treatments by looking at what we call differences in the median survival. So the median survival is when 50% of patients remain well and on treatment, and 50% of patients have progressed and needed further treatment. Now, for ibrutinib in this setting, the median PFS exceeds 5 years. So that means you've actually got, now that ibrutinib and BTK inhibitors have become the standard of care, certainly in the relapse setting, it means that we can't get a clinical trial result very quickly if we use those conventional ways of assessing trials. We're effectively having to wait at least 5 years before we get an answer. And actually, we'd obviously much rather prefer to be turning around trials in 2 and 3 years and then moving on to the next one if we were able to. Now, are there ways that we can do that? Are there things that we can measure that will allow us to do that? And this is the Aspen study. So this is the Beijing study that did a direct comparison of zanubrutinib versus ibrutinib. A fantastic study, and some of you online may well be participants of that trial. It's been published in Blood, and it's been just reviewed, and it's just been literally approved last week by the FDA. So with every expectation of European approval later on in the year. So very positive thing. And what Beijing did was that they persuaded the FDA to use response rather than progression intervals as their efficacy measure. And there is some validity to this. So we do know that your response at 6 months from any sort of therapy does appear to predict ultimately your progression. So maybe we should be looking at response, right, if we're looking at trials, and that will allow us to perform things in a much more meaningful time frame. So if you can imagine, you do a trial and you're not getting a readout for 7 years, a hell of a lot can happen in that time, and maybe your question is less relevant by the time you've got the answer. So another way that we can do this is by looking at bone marrow response. Can we quantify the amount of disease that's left in the bone marrow? And there's been a lot of work on this, and we've done a lot of this sort of work in Leeds, actually, both in the context of CLL and also myeloma. And this is what we call so-called minimal residual disease. So can we deplete the disease to such a level that we can't detect the cells in the bone marrow anymore? And what that has done in the context of CLL is that that's brought the concept of having time-limited treatment. So we know in CLL that there are combinations of drugs, and unfortunately for WM, CLL is always ahead of the game here in terms of delivering on such things, but we can learn from CLL. So this is work performed by my colleagues here, Pete Hillman and Andy Rawstron. We're looking at a combination of ibrutinib and venetoclax in CLL patients. Now you can see here on the left-hand image, you get very rapid depletion of blood disease, which is what one might expect at very low levels. But then if you look at the bone marrow, and to the right here, you're looking at bone marrows at varying intervals. You can see that the purple squares to the bottom of the right-hand columns reflects those patients, or the proportion of those patients who've depleted the disease completely from the marrow. So that what that means is you can potentially tailor the duration of therapy in these patients. So patients in whom you've achieved what we call MRD negativity, you would be potentially comfortable in stopping their treatment and maybe continuing on for those who have not. So that's an attractive option, and that's something that we can potentially use in WM. And this is data that we've generated here, actually, in the R2W trial, which is some years into follow-up now, and I know that there are patients on the line today who are in that trial. And we've been able to demonstrate with the flow cytometry, that's the fluorescent-based cellular assay, and that has a sensitivity. We can detect one WM cell in a background of 100,000 cells, And we can when we see that, we can see that those patients who deplete their disease below that threshold have a very good outcome. So this data is generated in the context of conventional chemotherapies and Velcade-based treatment, but you can see how it is potentially applicable to novel drug combinations in the future. So I think we might be using this sort of technology to assess response and to assess duration of targeted therapies. And obviously the goal for us in WM is very similar to what it has become in CLL, where CLL has effectively become a chemotherapy-free disease. Excuse me. So just a couple of quick slides to finish. And I think it's important that we recognise the value of real-world data, and that's data that's collected through registries and the like, and that's so that we're collecting information on a large number of patients, however they're treated, and this is increasingly used by regulators. Now, one of the things we need to remember is that real-world data will, by definition, always be different from clinical trial data, and that's generally because the populations that we're looking at are different, and also the robustness at which the tests are performed and the data is collected. So we know that in clinical trials, there'll be lots of scanning, there'll be lots of assessments that you do not get in routine clinical care. So in a sense, a clinical trial, it reflects perfect data, but it's an imperfect population because clinical trials by definition will exclude patients on the basis of low platelet counts or abnormal kidney function or a prior history of prostate cancer or something like that. Whereas real world data will include all patients, regardless of those comorbid factors. The data may not be as good because there'll be potentially fewer visits, fewer scans, missing data points, etc. But we should see these as complementary sources of data for evaluating clinical interventions. And just to kind of highlight the way that things are different, just in very, very simple terms. So if we look at the pivotal study from Steve Treon, first published 6 years ago, if we look at the median age for patients in that situation is 63. So, and if you look at the Southeast England registry, and this was a population-based registry some years ago now, run by Steve Skye at King's. The median age there was into the 70s. So you can see immediately that there is a decade difference between patients in clinical trials and all patients with WM. So we need to caveat our interpretations of both clinical trial and real world data and comparisons of the two with that in mind. And I think that's my last slide. And then I'll open the floor to Bob. Thank you.
Thank you, Roger. That was really interesting. I've got to tell you off actually right from the start because you referred to watch and wait, and I've been telling these guys for 4 months now. We don't call it that; we call it active monitoring. So okay. Next time I see you, Roger, you have to give me £1 for WMUK. I'm sorry. Yeah. Okay. So I explained at the beginning I've just moved today and literally set this up as the guys were still dropping furniture. So my book is in my car with the questions that some of you sent in. I'm going to ask the first question because I know it's flavour of the month. I don't know how it ties into your lab research, clinical research, but it's about COVID. Can you give us a current view as of today on either what you're doing in the lab about our COVID jabs, our antibodies, and whether we're going to benefit from a third jab? I think there's lots of questions about that. It doesn't relate to what you just told us, but have you got a view on it, Roger, just to put that one to bed?
Yeah, I'm just hoping we could put COVID to bed, really, but I think the concern is that patients with WM and other blood-based cancers will not respond to their COVID vaccines as well as other non-immunocompromised patients. And that's certainly true of patients who have recently received or are currently receiving rituximab, and it's certainly true of people receiving a BTK inhibitor. Now, what we don't know is that obviously everybody wants to get their antibodies tested, and you can test their antibodies, and there are varying ways that we do it. We are able to do it for our patients in the clinic here, but we simply get a qualitative result. So it's a yes or no. We don't know what that means. And nobody knows what it means. And so having antibodies in a sense has a degree of reassurance, but in no way, to me, should that make you modify your current behavior. There's still a lot of COVID out there, depending on where you live. And I would certainly continue to be somewhat cautious about that. In terms of knowing exactly what this means, then this is going to come out of the various formal studies that are happening, such as the OCTIV study. So we're recruiting patients into the OCTIV study, and there is an extension to that study to account for the potential for a third dose of vaccine. So I don't know what the data is that would suggest that you're going to respond to 3 when you haven't responded to 2. But to me, there's nothing to be lost from not having it, rather.
Good answer. Yeah. So because I've forgotten my questions, I know I got a late question or several questions today from Linda Berry. Linda, could you come off mute and ask perhaps one of those questions, the most important one to you?
Okay. A second. One of the questions, it sort of ties into something you said, which is CXCR4 is subclonal, but with BTK inhibitors, is there one of the BTK inhibitors that has a broader action that perhaps is more effective in someone, for example, with CXCR4, or do they all seem to be equally effective for CXCR4, sort of comparing zanubrutinib, ibrutinib, acalabrutinib? Any difference?
So basically the answer to your question is that from the original study and the curve I showed, the data would suggest that if you have a CXCR4 mutation, then your outcome is less good than if you don't have one. Mm-hmm. Now, it's less good, but it's still pretty good. Mm-hmm. And so what I wanted to highlight is that that's just one study. Mm-hmm. And it's really quite challenging to be looking at CXCR4 for all the reasons I said. So I think it's a bit too soon for us to be knowing what it really means. I think we need more information. There isn't, as far as I know, any, well, there's definitely no data on CXCR4 with acalabrutinib because it wasn't tested in that trial at the time. Mm-hmm. There is some data on CXCR4 in the Aspen zanubrutinib study, but I don't know what the results of it are. And I think the proportion of patients they were finding with the CXCR4 was relatively low compared to published data. And again, that immediately makes you think about, are they detecting them all? Yeah. So I think personally the jury is still very much out about CXCR4, and we just need a lot more data. So any new trial needs to be testing it. So for the Rainbow trial, for instance, we're doing the CXCR4 testing here. So ultimately we'll have some of our own data.
Okay, thank you.
Thank you, Roger. And I know that Dave Lee, you had a question which I think I wrote down in my book, but my book's in my car. So would you like to ask that question? You're still on mute, Dave. You're still on mute. Dave, you're on mute. That's it.
Well,
Yeah.
yeah, I was trying to understand about MYD88 when it attaches itself to the immature B cell. Is that site that the MYD88 attaches to, do other things attach to that site, or is that just for the MYD88?
So what we need to remember is this is all happening inside the cell. So we're mutating the gene, and when that gene makes the protein, it makes an abnormal protein. So all B cells will have MYD88, and that will perform a function that's essential for those B cells. In WM, you have mutated it, you've acquired the L265P, and then when you make the protein is abnormal and functions abnormally, and it's an activated, so it overactivates. So it's responding in a way that you might do if you were stimulated from the outside. So it's sort of stimulating itself. So it's activating itself, and it does so through that very complicated cascade that I showed. And that complex right at the start, which includes MYD88, also includes BTK. So what you're doing with ibrutinib, zanubrutinib, or whatever, is that you are indirectly inhibiting the effect of the overactive MYD88.
So do we have like healthy MYD88 and the mutated MYD88? So have we got some healthy MYD88 which produces the normal cell?
Yep.
Yeah.
So actually, we obviously have 2 copies of every gene. So every WM cell will have a normal copy of the MYD88 as well as the mutated. So that's part of the way we demonstrate the mutation, actually. Sorry, Deb, I didn't quite catch the second bit of your question.
Well, I was thinking that the MYD88, I wondered where it was produced, but you've answered that. You've said that it's actually within the B cell itself. Yeah.
Yes, it is. Yeah, so it's something that's occurring within.
Yeah, I thought it was produced outside and then attached itself to the B cell.
No, so what normally happens is that if a B cell is stimulated as part of your immune response, it will have stimuli from the outside. Well, then what that does, and there are a range of receptors on the outside of a B cell, and in normal situation, that generates a activation cascade to activate the B cells that will include MYD88. What you have in WM is you have a activated, overactive MYD88. So that, in a sense, that process is occurring without the need for the external stimuli. It's just a way that the cell is activating itself and making it into a WMB cell. So the way those experiments I showed you, where if you either affect BTK or you affect MYD88, you kill the WM cells, shows you that activation, that overactive MYD88, is needed for the WM cells to grow and survive. So it's central to the biology of the disease.
Very good, thank you.
Okay, guys, I've got to make an apology. I'm tethering off of my phone, so I can't see all on my screen. I can see 25 of you. So does anybody else want a question? I've got a question for Roger that I can see. You put your hand up. Or perhaps send me a chat that you want to ask him a question. Catherine Colebrook. So Catherine Colebrook, I can't see you, but perhaps you'd like to ask a question.
Yeah, hi. So 4 years ago, I was diagnosed with WM and cryoglobulinemia, and I've noticed on recent clinical letters that it talked about the cold agglutinin disease. Is that the same as cryoglobulinemia, or is that something different?
No, they're typically different things.
Okay.
So if you have a cryoglobulin, what that means is that there are several types of cryoglobulin, but essentially if you've got a cryoglobulin, your paraprotein precipitates when you're below 37 degrees. And it's a devil of a thing to try and get tested in the laboratory, because you probably noticed yourself that it ends up in a porter's pocket and cools down, and the lab can't do it, and that kind of thing. But cold agglutinin disease is also a temperature-related phenomenon, but your paraprotein in that situation binds to red cells when the temperature cools. So some of the symptoms can be similar. So you can get cold-induced symptoms of the extremities, but they're typically different things because the IgM paraprotein has got differing properties. The way cold agglutinin occurs is that is a bit like the mag neuropathy, actually, in that the paraprotein has what we call auto antibody specificity. So it recognizes a bit of you as if it were abnormal. So that's why in mag neuropathy, the IgM sticks to the mag on the nerve. In cold agglutinin disease, the IgM sticks to one of the molecules on the outside of the red cells called the I antigen, and it makes them stick together, but only on cooling.
Okay, thank you.
And I've just reminded myself of another question that somebody asked, Roger, so I'll ask it on their behalf. I'll come to you in a minute, Tom. And this is to do with hereditary. So I've got WM. Are my family, my blood family, more likely to be susceptible to WM or another blood cancer, or is it just is that not the case?
Okay, so there's a simple answer, and there's a short answer and a long answer. The short answer is no, there isn't a direct hereditary link, and so the MYD88 is an acquired abnormality. So that's not a transmissible genetic abnormality, say in the same way that you have cystic fibrosis or haemophilia and that kind of thing. But what you do have in Waldenstrom's is that you do potentially, for some families, to have a familial tendency, in the same way that some families have a lot of people with diabetes or heart disease and that kind of thing. This isn't something that we would advocate screening for, because I don't think there's much benefit from screening, particularly children or younger adults, screening them for a paraprotein, because I think you may well actually be doing them a disservice by finding one. And I very much don't screen family members unless there's a specific reason to do so, i.e. they're unwell.
Thank you for that, Roger. And that's interesting because my 38-year-old son is sat behind me, so you had to listen to that.
Yeah.
And Tom, you got a question?
Yeah, thanks, Bob. It related to the news last week about injection or infusion of monoclonal antibodies.
Yeah.
For those who are, the quote at the time that I read was, if you were in the top 1% of being extremely clinically vulnerable. And whether that's us lot.
I think it probably is. So we're still waiting to hear about that. So I was asking our pharmacist today actually about that. So we're still waiting to hear about the practicalities of that antibody. That's the jointly that's the one that Trump got, wasn't it?
And Richard Hanson.
Oh, hello, Bob. It's a question we submitted to you regarding being treated by ibrutinib on any relapse of the disease. We understand that you cannot have another BTK inhibitor. And I know that Roger isn't a fan of stem cell transplant. What options are available for someone who relapses with ibrutinib? And is it that correct that there are no further BTK inhibitors that can be prescribed?
So currently, if you progress on ibrutinib, then there probably isn't any merit in going on to acalabrutinib or zanubrutinib, because they effectively do very similar things. So there are trials of newer agents. So there is a compound that we've got a trial open here called LOXO 305, which is a BTK inhibitor but functions in a different way, and has been designed specifically to try and overcome the resistance that you get. So some patients become resistant to ibrutinib because they mutate the BTK binding site. So the place that your ibrutinib binds to on BTK is altered by a mutation, and then so this is a way, this is the sort of thing you see in bacteria when they mutate to become resistant to antibiotics. So there are emerging compounds. Now, as you say, I'm a little bit, well, I'm not a little bit, I'm quite a lot anti-stem cell transplantation, but that's not to say it's not an appropriate treatment for some patients. And the other thing is that depending on what treatment you've had before, if you do progress on a BTK inhibitor, you may well still respond to some form of more conventional chemotherapy depending on what you've had before. So if you've not had very much chemotherapy, you may well, so if you've had DRC before, for instance, you might respond to bendamustine, you might respond to bortezomib.
Yeah, well, Dorothy had matrix before she went on ibrutinib, and only had three courses of matrix because she'd had high dose chemotherapy before that. So
right, okay, yeah, that's a lot of treatment. Yeah.
So basically, at the moment, there's no approved treatment for someone who relapses on ibrutinib. Then basically. Other than going on a clinical trial if it does relapse.
Yes, I think currently for patients who've had a lot of treatment who relapse post to BTK, then that is a difficult situation.
Okay.
In the absence of a clinical trial, yeah.
Yeah, thank you.
I know that's not the answer you wanted, Richard. Sorry about that.
Well,
yeah, I'm going to take one more question from Vicky Towers. You there, Vicky? You're on mute.
Hi, everyone. Really, it was more about the bone marrow, so I don't know whether it's as appropriate, but I know I've seen Roger quite a few times. He's been amazing. And in the past, he actually asked my other consultant who I see about the MYD88. She wasn't aware of testing for that, and she did that. But earlier on, I'm still on active monitoring, and just for like own peace of mind. I mean, I had no idea how much, what percentage, and I know that's part of thinking about having treatment, not having treatment. There's so many different things. I'm lucky I'm not symptomatic, but how important is it to know? Because I tried to find out, and they said they only could find out that it was the MYD88, but they had no past history of how much infiltration, what percentage. Is it worth going through a bone marrow to find out that, or does it not really matter, Roger?
I think that if you're well, and we're not contemplating any treatment, then I wouldn't necessarily go ahead, and I don't think that would provide you with a great deal of additional information that would help at this stage.
Right. That's fine, yeah.
But if it comes to the point where you are having a discussion about treatment, then it would be sensible to do it, and then we can test for it.
And you have to see if it's going down, obviously, and the treatment's working from that, wouldn't you? Can I just tag on the end, obviously, Roger, saying that we might be in the 1% of the very, very vulnerable. And this is probably not a question most people want to hear, but obviously we never hear about the people who are sort of losing their lives because of COVID. But do you actually know, Roger, because you must have one of the largest database of Waldenstrom's patients within the UK, how it is affecting us if we get it? Because within our groups, I don't know anyone that's had it. You know, do you know the outcome for people that do catch it? I know that's a bit bit of a question to ask, but I don't really know, because I don't know whether Bob knows, but it doesn't seem to come up within our groups about anyone, because I think we're all being careful. How do we fare if we get it?
Well, I don't know that I can give you a proper answer to that in the sense that you
We're all
in terms of knowing that the mortality rate from COVID for people with WM is X%. I don't know what that is.
No.
But to say my clinical trial cohort, we've had 2 patients who've had COVID in the last couple of months, both on a BTK inhibitor, one on acalabrutinib, one on zanubrutinib.
Yeah.
They were both ill. One went to hospital, one didn't, but they did.
But they're alive.
They're both alive and kicking. Yeah. So it's not. So although I think it's not a given that you're going to die if you get COVID.
That's what. Yeah. I just sort of wanted to hear that. So that's lovely, and I'm sorry to ask that. Thank you so much, Roger. Thank you.
Good question, Vicky, and that's good for all of us to hear. I'm going to close it there. I know I can see Paul Brenchley asking a question, but
may I ask a question, please?
Okay, one question, yeah, and then that'll be it. Yeah, go ahead.
Okay, thanks very much, Bob. Roger, is there a specific CD marker on WM B cells that could be the target for a CAR T therapy? You'll be aware that this is being pursued in CLL.
Yeah, so the target would be the target for the CLL CAR T would be equally applicable.
So is anybody looking at using CAR T therapy for WM in the UK, in America?
So I think there have been some patients treated, certainly in the Sloan Kettering in New York. I'm not aware of patients in the UK having had it.
And do we have any data yet on how efficacious it might be?
I'm not aware of any. So basically the data is basically in the form of anecdotes of small numbers of patients at the moment.
And what would be your view of CAR T therapy? Do you think it's promising?
Well, clearly it's promising for a range of things. I think in terms of WM, it will be potentially only applicable for those patients who have difficult to treat disease. And hopefully that's not too many of you.
Thank you.
Thank you, Paul. And on that note, I can do an advertisement because tomorrow night at 6 o'clock, I'm doing a webinar with Dr. Maeve O'Reilly from UCLH on CAR T therapy. She's going to tell us what it's all about and what it may mean for us moving forward. So that was a very timely question, Paul. Thanks for that. It will not be recorded. She does not want to be recorded. So it will be a live one only. But I've got Joe, a colleague from WM UK, is going to take notes. So hopefully we'll have some sort of report afterwards that I can send out to any of you that want it. So anybody wants that to attend that, I've already put it on Facebook and the other things. But if you email me tonight or tomorrow, I can send you the link for that one, the CAR T one. So I just want to finally say a big thank you to Roger up there in Leeds. Thank you so much for tonight, Roger. Thank you for giving us your time. Thank you for being a trustee at WM UK. We really value you doing that for us. And I think I speak for everybody that tonight was really interesting. It's raised some really important questions, and you've given us some really important answers. So hopefully we've all got a better idea of what it is you do in the lab on our behalf. So thank you very much indeed.
Great, thank you. My pleasure.
Yeah. We ended up, by the way, Roger, with 48 of us at one point.
Right, okay.
But 2 did disappear, so yeah. Okay, so thanks everybody, and see some of you tomorrow night. And after that, the next webinar, I think it's the 14th of October, but I've got to check. The date is on peripheral neuropathy, and it's with Shirley Dessar and Professor Mike Lum.
It is the 14th, Bob, because it's my birthday and I remember it. So.
Oh, well, there you go. What a lovely way to spend your birthday, talking about peripheral neuropathy.
Thank you.
Yeah, okay.
Thanks,
so thank you,
Roger.
everybody.